Good morning, everybody. I appreciate you sticking around after the party last night. We're trying something new. Well, shockingly, we're trying something new for this Sunday, and we've dedicated the whole program on Sunday. And thanks to Phoenix Children's for sponsoring on surgeon wellness. Yeah, woo. We have all been to countless surgeon wellness talks. And my experience has been they're valuable. They share the breadth and scope of the problem. But I think we're just burned out, everybody. Everybody in this room is. It's not 75% over here that's burned out, or 70. We're all burned out. And those sessions have evolved into so much complaining, right? We don't need any more talks about how bad the problem is. I understand that to solve a problem, you have to identify it first. It's time to move on from identifying the problem and time to do something about it. The initial plan for this morning's first session was to take some of our pediatric surgery wellness experts and join them with the people we often blame for this problem, which is the leadership, the hospital CEOs, CMOs, department chairs, all those other things, in a discussion about how to move on from just so much complaining. Well, it turns out that if you are a hospital CEO, CMO, division chief, department head, you did not get there by being stupid and all of them said, no, I'm not coming. Why would you put yourself in that situation? So instead, what I'd like to start to do for all of today, starting this morning, is get past the complaining and get past the statistics and start to construct, start to put together, start to create the model of what a well pediatric surgeon looks like, right? So it's how many nights a call is that? How many APPs is that? A scribe. Try to create a picture of what the well pediatric surgeon looks like so that when we go to the CMOs and CEOs and the division chiefs, we can say, this is what we want, rather than just complain about working so hard. I want to thank Terry and the Wellness Committee. They've done a phenomenal job putting the program together in breakouts. Thanks very much.
So thank you very much. I have no disclosures, but plenty of recognition. First, I'd like to thank Dr. Powell, our president-elect, Dr. Tracy, the Board of Governors, for really challenging our committee to keep evolving our thinking about well-being. I want to thank the entire committee. Many are on the stage, many are in the background doing so much work throughout the year in championing this issue. And then for those of you that stayed, whether or not you're here in person, some of you that are virtual, and maybe some of you that are streaming from the airport with earbuds on. So we know that organizations have embedded wellness initiatives and programs into our local and shared environments in the recognition of the burnout epidemic, but those have been mostly focused on the individual. We have set up an amazing APSA peer support program for which we're very grateful for. M&M programs are shifting from shame and blame to learning and debriefing, both medically and emotionally. And the APSA annual meeting has provided a deep dive into education, which has always been focused on providing the optimal care for our patients. However, I am so happy that we're now expanding this to include the optimal care for ourselves. So the goals of our session today is to really talk out loud about ways to promote a sustainable lifestyle for our pediatric surgical family so that we can continue to bring our best selves to those we serve and those that support us at home. We want to normalize that water cooler conversation around issues that we can name, tackle, and then collectively create solutions. And then really we want this to serve as a springboard to engage our membership into shaping our healthy professional culture. So the overview of the morning is we're going to provide now a sneak peek into 6 concurrent sessions. We'd love you to attend 3 of the 6 sessions and then return to this main room for a wrap-up. We're going to articulate the take-home points from each session to embrace our goal of visioning the well-adjusted pediatric surgeon. So with that, I'd like to invite Dr. Crowley to the platform to talk about her session.
Good morning. My name is Helena Crowley, and I'm from the University of Maryland Children's Hospital. And on behalf of my team, Dr. Bob Sawan, Dr. Kurt Heiss, it is my privilege to invite you to our break shop session entitled Navigating Responses to Toxic Work Encounters. To be transparent, we would like to disclose that both Bob and Kurt serve as professional coaches. During our session, we're going to talk about the top 5 attributes that are common among a toxic work environment. We're going to talk about the far-reaching and measurable impact of a toxic work environment in a medical setting. That includes staff and patients, as well as the organization as a whole. And in addition, and perhaps most importantly, we're going to offer you some techniques or tools, if you will, to navigate these difficult experiences. So this session offers you a very unique opportunity to learn from your peers. We're not going to teach you, we're going to teach each other. And we're going to do that through our shared experiences and insight. To have a conversation about a toxic work environment, you really need to define the word toxic. And that can vary dramatically depending on who you ask. It can range from annoying to abusive. If you ask the Merriam-Webster dictionary, toxic is a material capable of causing debilitation or death. If you ask OSHA, it's a physical hazard or a health hazard. If you ask Britney Spears, it's a poison paradise. So there are many representations of what is toxic. To borrow a very famous phrase in the history of the Supreme Court, toxic might be a scenario where I know it when I see it. Have you seen the 1999 cult classic Office Space, where the beleaguered Initech employees are harassed by their boss about the TPS report? I'd call that a toxic work environment. Perhaps I know it when I hear it. These statements were reportedly made by a renowned surgeon. The last statement was actually a command. The trainee would literally stand in the corner of the room. This was not a Hollywood movie, this was their reality. So if the definition of toxicity depends on who you ask, the more people you ask, you're going to get a more meaningful answer. 1.3 million people were queried, employees from Culture 500 companies representing 40 distinct industries. And these were the top 5 attributes that they spoke about when referring to a toxic work environment. And we're going to discuss those during this session. So whether you see it, you hear it, or you feel it, there is no question that toxicity is in the work environment and it has a far-reaching impact. For patients, it causes poor communication, which results in medical errors. That harms patients. For staff in toxic work environments, there are higher levels of mental health disorders, including depression and anxiety, as well as other diseases like coronary artery disease, diabetes, arthritis, and asthma. And these illnesses financially impact the institutions because they result in employee absences. In addition, they result in employee attrition, and that has massive financial implications. It can take up to twice the salary of an employee to replace them. To combat toxicity, which we know exists, we need tools, simple tools that'll help us navigate these difficult conversations. And we're going to discuss these during our session. We're going to delve into the concepts of using this idea of a North Star and what is your circle of influence to navigate these difficult conversations. But we're also going to explore our own role in contributing to toxicity. So during this session, we are going to have some very carefully curated scenarios where we can discuss the attributes, the impact, and how to mitigate the toxicity. We're going to embrace the awkwardness. We're going to tackle toxicity together. So on behalf of Kurt and Bob, I'd like to extend an invitation to you to be our guest and tackle this beast of a topic together so that we can start this important conversation for the ABSA community. Thank you. I would like to invite Hal Lay up next. He's going to discuss ergonomics in the OR environment.
right, thank you. I actually don't have any slide. So who in here think, what the most equipment that you have in the OR? Okay, name it. What is the most equipment you have in the OR, most expensive? Okay, good. Well, you guys are probably smarter than I am because when somebody asks me that question, I say, probably a robot, right? Costs a few $1 million. And how much money you think we spend to maintain a robot a year? Upward of 100, 200K a year, right? And if you have a robot in the OR, you don't actually just take it out, use it, and put it away, right? You have to maintain it. You don't use it all the time. You have to sign up. There's a seat that you have to sign up. Make sure that you have the schedule correctly. But just like some of you said, the surgeon, or we are the body, is actually the most expensive, the most valuable equipment that we have in the OR. And how much time and how much resources we use to maintain ourselves, our body. So this morning, early on, you heard about the spiritual aspect of surgeon, and I would equivalent that to the software that how we run, right? So if you have a piece of equipment, you have the hardware and you have the software. So for a surgeon, our spiritual aspect is basically the software that how we run. But if we don't take care of the hardware, it's gonna wear and tear, it's gonna break, and doesn't matter how good your software is, it's not gonna work. So this session basically gonna dive a little bit into how we're able to maintain, okay, how we use our hardware, our body, in a way that we can make it last as long as possible and more efficiently. And then not only that, this equipment you bring home, right? You don't bring the robot home. You're gonna bring this equipment home, and they do many other things at home, cooking, cleaning up the house, taking care of the kid, right? Play with grandkids. So this equipment needs to be maintained in a way that not only you use in the OR, but you're gonna use it at home, okay? So this is not just ergonomic in the OR. This is a little bit misnomer. But we will discuss how you're able to work in the OR, how to position yourself, the patient, the table, or the equipment in a way that you will work better and more efficiently in the OR to reduce injury that relate to poor ergonomics. We recently sent a survey out to absent members, and thank you for those who responded to them. Based on the result of the data, which will be presented at another meeting, but I just want to give you a little sneak peek into that. There's 90% of survey respondents respond that they have some discomfort or injury or pain that require them to do some treatment. And some of that is over-the-counter medication, some of it is prescription medication, and some of that are surgery procedure that relieve the pain. So almost all of us have some ergonomic-related injury or pain discomfort. So this is very pervasive. Only 18% of us actually receive any training in ergonomics. And this is just the ergonomic in the OR. So there's a lot of resources. The ACS have a page on a website on ergonomics and how to optimize ourselves. But we will discuss how we repair ourselves before the OR, right? And also after the OR, so that we're able to maintain this equipment, this most valuable equipment. Please come to our breakout session, and we'll discuss more about that. Thank you. So next, I would like to introduce Christine Velasco, and she'll talk about how to be a supportive colleague for the lactating surgeon.
Thank you, everyone. So in my group, we have Dr. Catherine Nguyen, who is a neonatologist and lactation consultant. After seeing the importance of breastfeeding, she decided to pursue that to help her patients and also help us surgeons and colleagues in Orlando with me. We have Julie Montegudo at Brown, as well as my partner Brenna Fullerton at Arnold Palmer, and I am three of them are all moms and awesome physicians, and I am the supportive colleague and the wellness committee member that was able to bring this topic to this forum. So we had so many great discussions in the past at APSA with Benji Brooks and other topics with dealing with fertility, being pregnant while you're at work and the complications that can come from that. So we wanted to discuss what happens once you're coming back to work and how we can help our partners who are going through that. So as we know, breastfeeding goes down as the child gets older. In the U.S., the number of infants that are exclusively breastfed at 6 months drops to 25%, down from 45% at 3 months of age, and this is thought to be in part due to many mothers returning to work. And according to AAP, children who are breastfed have improved neurodevelopmental outcomes and a better long-term physical and dental health outcomes. In addition, breastfeeding contributes to promoting maternal health with decreased risk of certain cancers, type 2 diabetes, hypertension, and postpartum depression. Interestingly, Catherine found that breastfeeding one baby for a year takes roughly 1,800 hours, and a full-time job with 3 weeks vacation is over 1,900 hours. So really, you're doing 2 full-time jobs when you're a surgeon returning to work, and let's be honest, many of us work more than 1,900 hours as it is. And UCSF offers lactation credits for ambulatory physicians with 1.92 work RVUs and a 30-minute lactation hold per half-day clinic up to 1 year. APPs also have an option for this there with an adjusted work RVU, and it would be great to see more hospitals take this idea and run with it. Hot off the press is a statement from the American College of Surgeons that was just released last week with a revised statement for the importance of workplace support for pregnancy, parental leave, and lactation for practicing surgeons. This was approved by the Board of Regents back in February, and they recognize that women, when they return to work, need to have time every 3 to 4 hours to pump in order to provide sufficient milk for their infants at home, and that we should be, as institutions and colleagues, providing this time to allow them to leave the operating room or clinic in order to do so. Lately, there's been a lot of studies looking at breastfeeding and returning to work, and one study looked at teaching faculty, and a survey was sent to them. Nearly all surgeons felt comfortable discussing it. Talking with my break shop members, they felt like probably if you got into a little bit too much detail, then they wouldn't have been as comfortable talking about it. So that's what we want to be able to get everyone to the point that we can discuss this openly. And then only 2/3 of the people actually felt that institutions were supportive of this. And then there was some discussion about whether or not breaking to pump interrupts the operating room workflow, and people thought it didn't, but still didn't really feel that they could go do it. On the other hand, the slide doesn't work. Sorry, guys. There was a study looking at surgical residents, and they found that 2/3 felt that they didn't have adequate time in order to go pump and didn't feel that they had support of the residency program. So obviously there's room for us to grow with that. And then this is a great website. I've included the QR code, a resource for physicians returning to work. Catherine described Dr. Katrina Mitchell as a badass surgeon who has published a lot about breastfeeding medicine and has a great website for women returning. So goals of our session are to provide ways that colleagues can support their postpartum partners when they return to work, discuss ways that we can improve this experience and support that's provided by hospitals, as well as provide some tips and tricks for pumping at work, managing breastfeeding duties at work and home. Both Brenna and Julie have done this both in residency, fellowship, and then as an attending, so have a wealth of experience of how they've been able to do it and are happy to help. And we are also want to learn from everyone. So we hope you'll join us. So next, thank you, is Yu Young Hu, and she'll be discussing onboarding families to the pediatric surgeon lifestyle.
Good morning. I'm Yaron Hu. I'm a pediatric surgeon at Lurie Children's. I'm also one of the PIs of the second trial, which is a study of resident well-being. In the beginning of the trial, so 2019, 2020, before COVID shut us down, we were traveling to different general surgery residency programs throughout the country to understand what different places do around wellness. And one of the most transformative things we saw was at the University of Rochester, where they do a family orientation. So new interns, a month after they start, bring their family to a session where they are taught about what it is to be the family of a surgeon, what the life of a surgeon is like, and what everybody is going to be experiencing over the next couple of years. And I thought that was just such an amazing concept. We spend so much time orienting new interns into how to answer pages, how to, what to do when they get stuck, but no one tells their families, like, this is how it's going to be forever, basically. So our session, it's sort of based on that. I just realized I forgot to put the slide up. Hang on. Our session is supposed to be around how can we create that same concept for surgeons at all levels. So we want to help systems leaders and personal networks understand the facets of work and life for a new pediatric surgeon, so a really holistic look at how to set up surgeons for success. Outline opportunities for practice partners and hospital administration to provide support for a new surgeon and their family. So not only is it about explaining to a surgeon what their family might be encountering, but also the family about what their loved one who's a surgeon is facing, and then review knowledge, skills, and resources for surgeons' families on how to recognize and respond to common stressors that new surgeons face. So again, an opportunity for families to learn how to support us, as well as families to understand that they may need support themselves, and where to get that support. And we're really lucky to be joined by Lauren DeCaprio-Ryan, who is a psychologist within the University of Rochester General Surgery Program, who leads family orientation there, as well as Michael Ishitani, who's done many years of onboarding new surgeons at the Mayo. Thank you.
Good morning, everyone. I'm Steve Stilianos, and thanks, King. I just wanted to start by thanking Dave and Tom for continuing to push APSA to a place that encourages and fosters connection, encourages inspirational vulnerability. It's an APSA that's a little bit different than what we were brought up in, and dare I say, it's a bit better, too. So thanks. Let's see if we can go here. When I first saw this slide, I recoiled a little bit. When I thought about it, a room full of pediatric surgeons, we would say that pediatric surgery isn't just what I do, it's who I am. And I think many of us would subscribe to that. But in addition to that, which brings us such great joy, we are other things. We have parents, we have partners, we are raising children, we're part of a spiritual community, we're civically and globally conscious. And as our workplace squeezes more and more time away from those other activities, we're left somewhat frustrated. And I heard the term earlier during the session about enduring. We should not be just enduring our careers, even though we love what we do. So, a few things about what we're not going to be speaking on. we can't just turn the clock and make a 4-day work week because, as we all know, children, they tend to get sick on every day of the week. But changing the culture of what the workplace should be like is something that we can do, and we can eliminate some of the frustration of not being able to devote enough time to the other aspects of our lives. Now, a few things, again, what we're not going to do. You're not going to be sitting on the beach with a drink, with an umbrella, and someone else is going to be doing the work for you, okay? In New Jersey, we call that a no-show job, as my friends on the bottom there will talk to you about. This is what Brath and I want to propose, that all of us take back and think about how does it fit into our practices, whether you're in a faculty of 20 or you're in a private practice group of 2 or 3. It's simply to gain a little bit of the autonomy that we feel we have lost because of all of the pressures of our jobs. And you know, here are all the different reasons why that occurs. We all know those. How many of you finish your medical records at 11 o'clock at night, you know, after you've helped the kids with their homework, you know, caught up with your spouse for about 45 seconds, and they say to you, "Is that all I get tonight?" It shouldn't be that way. It really shouldn't. So this is the money slide. We're not, you know, we're going to be a cappella in the break shop, so this is the money slide for you if you want to accept it. You will not work less, but you'll work better, and you will spend less time at work, allowing you to devote some of that extra time back to people and to things that you love, that are part of you. What will this require? This is the absolute requirements. You must have personal discipline to get this done. You must have group agreement, and the members of your group are part of your family, and you must agree that this is an equitable and a wonderful thing to do, and the chief has to be a champion of this. If the chief obstructs this, it's not going to work. Here's another money slide, more graphically. What if I proposed to you that you could go back home, do 100% of your work, be compensated 100% of your salary, but do it in 80% of the time, giving you back that 20% to devote to things that are who you are also. Now, who supports this? The Surgeon General says that the framework for workplace mental health and well-being is down at the bottom there in orange, I think it is, work-life harmony. Okay, so the Surgeon General supports it. The American College of Surgeons supports it, speaking on well-being, resilience, and work-life integration. Remember, the term work-life balance is being sunsetted. That implies that you have work and that you have a life, but work is part of our lives. And so we're talking about more integration and harmony. We can skip this slide. You know, there's a lot written about this in the business community. This works in the business community. You know, all they care about is profit and loss, and they would not do this if it didn't work. This works, and it's just spreading like wildfire, and it's almost an expectation now that you can tailor your work environment to fit your needs. So work less, do more, work less, live more, work less, make more. Thousands of books that drive you crazy. Ooh, the last slide went away. So sorry. What this slide says, or is supposed to say, is that if you don't control your life, someone else will. And so that's what our session is going to be about. Brath and I hope that you will join us, and we look forward to a spirited conversation. Thank you. I'd like to bring up Terry to finish or start.
Great, thank you so much, Steve. Pleasure of chairing this last session with Mary Brandt, who's been a real inspiration to this topic. So I'm not going to do a poll, but I want you to think about the answers to these questions and these potential scenarios about whether or not you should come to work. You are in the ER with abdominal pain and a new tumor diagnosis. Your family pet collapsed at home and died. You have norovirus with voluminous side effects. Your parent, for whom you are caretaker, just fell and has a broken hip. You're taking a red-eye home from your cousin's funeral after he died in a ski accident several days prior. You're signing divorce papers. These are all hypothetical examples, but do we really need to cancel our day? Well, we all share a deep personal responsibility to our patients. But are there guidelines in your practice that are articulated for when you have permission to cancel your day? Is there an emergency coverage plan in place? If my mom tells me one more time, when is your sick day? I've been laughing at that for 30 years because we don't have a sick day. Who's the decision maker in your practice? How do you reschedule? What is the threshold for activation if you must cancel your day? And I would submit that if these are nebulous, we're probably just going to suck it up and show up. But COVID really mandated that we flex. We had no choice, if we were COVID positive, to be away on very short notice, and somehow our patients got cared for and we survived. So I think this is doable. Well, I want to tell you that those hypothetical examples were actually not hypothetical. They're all mine. And are you surprised that I told you about them? Because you could probably all stand here and have your own examples. So the goal of our breakout session is to empower autonomy to recognize when you need a day away. Explore solutions that I may not know about that you may have in place in your practice. We want to normalize this conversation and then work toward best practices so that we can continue to take the best care of ourselves and therefore the best care of our patients. So that's a little sneak peek into our session. All right. So at this point, we'd like to invite you into the breakout sessions. Again, there's time for 3 sessions out of the 6, and we really want you to put on your thinking caps, and we look forward looking forward to the commentary and having your ideas about these all very individually but globally important issues. So thank you very much for your attendance again, and we look forward to meeting back in this room if you're able to stay at 11:30. Thank you.